Okay, gang, so this is video 2, hopefully of 2, for Tetralogy of Fallot. So let's go back to our assessment pieces. So obviously we are going to expect to see cyanosis, signs and symptoms of hypoxia in the peripheral tissues, so that'll be the mouth, hands, and feet. And then we could even see this perioral cyanosis, so we're talking about the mouth area here, and you see this cyanosis up here above the mouth, so that's also another clinical finding. So as far as what are we going to assess for our nursing and implementations here, so we want to ask also the mother, any history of any infections during the pregnancy, viral infections, German measles, anything like that. Look at her age, is she above 40? Ask about any family history of any congenital heart defects. Okay, so we want to ask about all of that. Any substance abuse during the pregnancy, smoking, etc., use of street drugs, all of that. We want to ask about that because that's going to be helpful in figuring out where this came from. Again, ask family history, any congenital defects at all, any SIDS, any cardiomyopathies, any heart problems whatsoever. Depending on how old the child is when they're diagnosed, so whether they are an hour old or a month old, we need to consider their nutritional state. Why? Again, because it's hard for them to eat. It causes severe hypoxemia, which leads to hypoxia. So may have failure to thrive or be underweight. Their general color, again, we're looking at these extremities, the mouth, and the hands and the feet for any discolorations or bluish. Signs and symptoms of cyanosis, basically. Any chest deformities, as far as anything looks funky in their chest there. See if we can feel any unusual pulsations. How is their overall respiratory status? Do they seem to be gasping for air or in a constant state of respiratory distress? Want to look at clubbing. If you don't know what clubbing is, look that up. That's basically caused by hypoxia that occurs over time, and the fingers begin to, from the lack of oxygen, begin to basically thicken, and they look like little tiny clubs on the end. They get, instead of being tapered and or just one size like the rest of the finger, you get like this big finger nail pad or big pad at the fingertip, so it's like clubbing. And then of course we are going to look, listen, and feel to the heart chest area, especially. That's going to be our focused assessment. It's going to be cardiopulmonary assessment focus there. As far as diagnostic tests that they would run, or that you would expect to be ordered, chest x-ray. And why do we do a chest x-ray? It's not going to help us with anything necessarily. We may already have the diagnosis. What a chest x-ray can do for us is provide a permanent record of the state of the hypertrophy. Because remember, we always have to get a baseline. If we don't get a baseline, then we have nothing to compare to as to whether something has gotten worse or something has gotten better. So we need a baseline examination for the permanent medical record. And in children with the Tetralogy of Fallot, due to the right ventricular hypertrophy, and that overriding aorta and the pressure differentials, you'll see this, this hypertrophy out here. It pushes everything over, and they call it a boot-shaped heart. So they've got this little boot in there, so you can see what somebody was imagining there when they started calling it a boot-shaped heart. ECG, this just tells you, obviously, remember that electricity runs inside of the heart muscle, and if the heart muscles are altered, and the cells inside of them may or may not be responding, or may need a little bit more oomph and electricity behind them to get the heart pumping and get blood moving through here, we're going to see some changes. So nothing for you to really, I guess nothing you need to commit to memory here. I'm not looking for specifics, like you need to know how many milliamps or which leads are going to be you're going to see changes in if you just are aware that there will be ECG changes in Tetralogy of Fallot. And then we can do our echocardiogram, which remember we said last night, we're going to do a little picture, gram or graphy, as we're talking about graphing out or taking a picture of something with echo waves, so or echoes, and it's going to be of the heart. So you can see this is pretty funky looking here. I put a picture of a nice normal one here, so you can see our normal heart here. Do you see how the right ventricle is normally pretty small compared to the left, and it's normally this nice like 4 thing here, and here's our tricuspid, and here's our mitral or bicuspid valve over here. And this one's just a mess. Granted, the orientation is a little bit different because it was taken from a different view of the heart, but you can see we don't have any nice closure here. We can see our overriding aorta up in here, and then our wall between the two that's not supposed to be here. So this is up here. Here is the same as down here. So there's that opening in the wall, and then we can see the aortic, the overriding aorta that's right on the other side of this ventricular septal defect here. So not good. And that's going to tell us, why do we do this echo? We do this echo so we can learn about the severity of the stenosis, the severity of the hypertrophy. It shows us that, this thickening of the right ventricle. You can see it's almost as thick as the left ventricle. That's not normal. So this is a good tool for documentation, but also to determine some of the extent of the issues that we're dealing with. And then same thing with our cardiac catheterization. We can do this in babies. We normally see it done in adults. We talked about this yesterday as far as our angiography, and you can do this angiography in the babies here to see the extent of pulmonary stenosis and the mixing of the blood here. And so that's what, that's what we're looking at here. And then also for diagnostics, a CBC and coagulation. And what you'll expect with these is you'll expect to see that the clotting time is prolonged, which makes sense because we said, you know, that they're at risk for emboli because of the blood kind of sitting and pooling in the inside of the heart, and it's not being moved through like it normally does, so it's kind of clogged up in there. So we'll anticipate that our clotting time is going to take longer than normal. And for our CBC, we expect that our hemoglobin and hematocrit will be elevated. And why will they be elevated? They'll be elevated in response to our oxygen demand. So in order to try and meet the oxygen demands of the body, remember that hematocrit is referring to part of the red blood cells, and that the red blood cells have an appendage on them, which is hemoglobin, which helps it bind to oxygen, if you will, and kind of like we can't, it would be very difficult to pick up a mug of hot coffee with our toes, unless you're extremely talented. And maybe you're going to try it, I don't know, but please don't burn yourself, as opposed to our hand. And so if you think about hemoglobin is like a hand, and oxygen is that hot coffee. We've got to have our hand of hemoglobin to pick up the oxygen. So our body's going to make more of both of these things in response to the oxygen demands of both the myocardium and the peripheral tissues here. So here's a little baby that is in the NICU, I sure hope, and has just had a cardiac catheterization. I found some other pictures, but I didn't find one that I liked as well as this. And we can see this. He's got a catheter. He's got a chest tube coming out here. That's a chest tube, guys, going into his little tiny baby chest. And he's intubated. There's the endotracheal tube over there. And have this little thing on here, and his sat probes and stuff holding his ankles in place, and making sure he must have an IV or something over here. Maybe has an IV in the foot. I've got a little sat probe over there. So anyhow, this little baby's just had a cardiac catheterization, and that could have been, it's not explained where I got the picture, but it could have been either diagnostic or to do some therapeutic procedures, which we'll talk about in a second. So, so there's some stuff that you can think about just as far as your assessment pieces and look up. So assessment-wise, we're going to be obviously, with the baby, we can't really talk to them. I mean, we can talk to them, but you know, they can't give us back useful information about their symptoms. I've never heard a baby actually tell you, you know, oh, I'm feeling short of breath. So, so we're going to have to assess that. So we're going to have to do our cardiopulmonary assessments and our neurovascular assessments and vital signs, and a lot of education and a lot of psychosocial support and a lot of coordination of care, because these babies need to go be transferred to a higher level of care, go to a children's hospital where they specialize in care and repair. And then our diagnostics again, preparing and getting ready for that. So, you know, the parent may want to hold the child on their lap during some of the procedures. Well, we can't do that while we take an x-ray, because then we'll get the mom's bones or the dad's bones in there, and plus we're exposing them to more radiation, so we don't want that. An echo and an MRI, we need them to be very still, and we've got to be able to take the pictures in the correct, while the baby is in the correct placement. So like for an echocardiogram as an adult, where, you know, you kind of tilt on your left side and you hold your left arm up a certain way and all this stuff. And babies, we need to make sure that we have them in the right position. So, excuse me, getting the parents involved holding the child is not a good intervention for these diagnostic testing. Instead, what we'll do is, and again, this is why they have to go to a higher level of care, so that you can have specially trained individuals to help give these babies a mild sedative, so that we can get our diagnostic test done. So as children grow with these, especially, we will have to look at psychosocial well-being, because imagine, you know, oh, I'm only 12 and I had 3 heart surgeries already, and I can't play sports, and I'm short of breath, and I feel fatigued all the time, and I'm on all these medications, and it can be very demoralizing in a psychosocial sense here. So just some things for you to think about here, which, well, I already told you that which antecedent was compromised, and then which attributes are going to be different than your optimal ones. You can look at that. Look at the interrelated concepts. I really hope that gas exchange comes right to mind. And then our negative outcomes, consequences. You can go back to the first PowerPoint and put the links together there. So treatment here. So this is really characteristics, the squatting one. So this is the knee to chest position, and something I want you to know about. Have you ever had been short of breath or dizzy and somebody says, just put your head between your knees? And what you're doing is really you're bringing yourself into this squatting position so that you can decrease your overall oxygen demand, and you can focus on just supplying oxygen to the heart. So you'll see this very characteristic, and that's part of how it's diagnosed, you know, and little toddlers and stuff running around with this will, when their oxygen demand gets too high, they'll naturally go ahead and get into this squatting position, and it increases the afterload and helps with their oxygen demand. And of course, oxygen, we know that they are a little short there, so they need some. And then fluids just to help increase the systemic pressure here. Beta blockers, sorry, I skipped over those, are just to help improve the contractility of the heart and slow the overall heart rate. So surgical, I don't want to tell you, like, go too in depth with these, because this isn't, unless you go work at a children's hospital and you'll get special training for that. So just be aware, have these on your radar, that these are the kind of things that they can do. There are palliative things that they can do, put a palliative shunt in, open up a little hole, it's called atrial septostomy in the atrium to help release pressures. And the main thing that I do want you to know about that is that palliative procedures are performed until the baby is old enough and well enough to receive open heart surgery. Yes, little tiny babies. Look at that. He got his little tiny chest cracked open. Just thought that was so cute. Anyways, so this is our prognosis. Pretty good. We've got a lot of improved surgical techniques, and go ahead and review those on your own. And that is Tetralogy of Fallot.